Hi, it's Tilly here again. I'll be talking today about part 2 of secondary care dermatology. I'm here today with Poppy, my dog. I'll just go and get her. So I wanted to introduce Poppy because I watched part 1 back and I could hear a weird noise in the background, and I've realised that it is Poppy snoring. So I just wanted to show you who was making that noise, and hopefully it won't have the same effect on you. Okay. So on to the talk for today, and that is part 2. In part 1, we finished with blistering dermatoses, or blistering skin conditions. We're now moving on to infections. So we're going to start with infections that are fairly superficial in the skin, and that is impetigo. We talked about impetigo in part 1. Just a quick recap that there are 3 different types. The non-bullous form, which is the most common, and this tends to have the golden or honey-coloured crust. It's quite often treated with topical fusidic acid, and that's because it tends to be a Staph aureus infection. The second type is the bullous form. This forms bully, as can be seen on the second image down. And you sometimes see a golden crust with this type, but not always. The final type is Exanthem, which forms deep ulcers, as you can see in the image on the bottom right. Going deeper into the dermis and local lymphatics is Erysipelas, or Erysipelas. Again, I'm not sure if I'm pronouncing that correctly. This infection is seen in the upper dermis, and it's usually caused by Streptococcus pyogenes. It usually has an abrupt onset and can be described as firm. It shows the cardinal features of inflammation, that is, it's red, it's swollen, it's warm and tender. Other signs that might be seen are lymphadenopathy, dimpling, blisters, and purpura. And the image on the top right shows some purpura within Erysipelas. It's a sharply defined, well-raised border, and it can affect any part of the body, but it's especially seen on the legs and face. You can see on the right-hand side, the side of somebody's face, and you can see blisters at the bottom of the image, and in the middle, the front of the face, and it has a butterfly distribution on this lady. It's painful, and as well as these local symptoms, it can have systemic symptoms if it started to spread. Investigations include bloods and cultures, and treatment is similar to cellulitis, which I'm going to talk about on the next slide. So if we go deeper still through the tissue, we get to the lower dermis and subcutaneous tissue, and this is the location of cellulitis. The most common causes of cellulitis are Staphylococcus and streptococcal species, examples of which would be Staph aureus and strep pyogenes, but other bacteria can cause it as well. It's more likely to occur if you've had local trauma, so for example, athlete's foot, cuts on the skin, venous insufficiency or ulcers. And there are some conditions that are predisposing to cellulitis, so for example, poorly controlled diabetes, CKD, or immunodeficiency. Again, similar to Erysipelas, it has the cardinal signs of inflammation, so tender, red, warm, and edematous. However, unlike Erysipelas, it's got indistinct borders, and it's not as raised. It can have similar things to, as I described before, so blistering, dimpled skin or peau d'orange, erosions, ulceration, purpura, and bruises in general, or ecchymoses. If the bacteria spread to lymph nodes and local lymph glands, you get lymphangitis or lymphadenitis. And in the bottom right image here, we can see a red line tracking up this patient's arm. And this shows lymphadenitis. It's tracking from the site of infection to a nearby lymph gland. It tends to affect the limbs, and it's normally unilateral. So on the image on the top right, you can see this patient's left leg is infected. If it affects the eye area, it's called periorbital cellulitis or preseptal cellulitis. The more serious infection around the eye is orbital cellulitis, but that's covered in a different series. The image on the top left shows periorbital cellulitis. And again, as with any local infection, if it spreads, you can get systemic symptoms. On the top right of this slide, this is another important example of a cellulitis infection, and that is an iatrogenic cellulitis. And it's obviously important for us to look out for things like this. For both cellulitis and erysipelas, it's important to determine if the infection is spreading. So in the bottom right, you can see marking that's been done on the right leg of this patient. You'd watch that as time goes on and see whether it expands or decreases, and whether it decreases in response to treatment. In terms of other investigations, bloods are important, so white blood cells, CRP, cultures, and you'd want to differentiate it from a DVT. However, D-dimer isn't useful as it's also raised in infections. So you do a Wells score, and if this raised the possibility of a DVT, you'd carry out ultrasound. Diagnosis tends to be clinical. In terms of treatment, rest and elevate the limb. This reduces swelling. You can use compression stockings, cold packs and analgesia. Wound care is needed. And antibiotics to treat the infection. If they're systemically well, oral, or if they're systemically upset, IV. And local guidelines direct the antibiotics to use. Although it's worth bearing in mind that most infections are caused by staph and strep, and because these are gram-positive bacteria, which means they've got that thick peptidoglycan outer layer, they need antibiotics that will target that layer. And the most common example of these is penicillins. So in terms of ongoing care, avoiding trauma is important. So for example, wearing long sleeves when gardening. Keeping skin clean and well moisturisers and nails trim. Treating fungal infections early and elevating swollen limbs to aid with lymphatic circulation. If treated, cellulitis generally doesn't scar. However, it can lead on to more serious infections. So as mentioned earlier, it can lead on to sepsis. It can affect other organs, so for example, osteomyelitis, pneumonia, or meningitis. And it can cause gangrene. And we'd be particularly concerned about gas gangrene and necrotizing fasciitis, both of which I'll cover in the following slides. So going deeper, and this takes us on to gangrene. Gangrene is a localized death of tissue. And there are a number of causes, and these causes determine the type of gangrene. Two main types are dry and wet. Dry results from chronic ischemic tissue that isn't infected. The lack of oxygen means there's little bacterial growth, but the tissue also dies. In a limb, this ischemia is called dry gangrene, but elsewhere it's just called ischemia. So for example, mesenteric ischemia, which would be gangrene of the small intestines, or gangrene of the large intestines, ischemic colitis. So on the top right, this is quite an old picture of dry gangrene. It tends to develop, for example, in smokers or people who have diabetes or arteriosclerosis. And you can get the impression from that image that it's a well-defined, dry, shrunken, red-black area of tissue. It tends to be painless. It's necrotic tissue and ultimately will fall off in a process called autoamputation. Once it's developed, the tissue isn't salvageable. Treatment can be conservative while awaiting autoamputation, or it can be surgically debrided or amputated, and this may help avoid infection. An important consideration of dry gangrene is that it can progress into wet gangrene. So wet gangrene, the bottom two images show this. This is where the gangrene is infected. It's colonised by necrotic bacteria, and in general we see swelling from that local infection, which stops blood flow, and this blood stasis facilitates bacterial colonisation, and it also means the immune system is less able to reach the infected area. There are different types of wet gangrene caused by different bacteria, and we'll talk about those types more in the next couple of slides. Initially it can look like cellulitis, but then it obviously progresses, and these signs or symptoms include discoloration. It's got a particularly foul smell, and the infections may progress despite antibiotic treatment. Blisters may form, and they can be hemorrhagic. Bruising can be seen. Crepes can be felt, and we'll talk about this more in the next slide. And although it's normally painful, there may be some early cutaneous anaesthesia. It quickly progresses and can lead to necrosis, sepsis, and toxic shock syndrome. This is where toxins from the bacteria are absorbed systemically. Wet gangrene is an emergency and needs to be treated fairly quickly. There are a range of investigations that should be done. So bloods, including creatinine kinase to monitor muscle damage, FPCs, blood cultures and local cultures should be done. There are a couple of important types of wet gangrene. The first is gas gangrene. This is typically caused by a bacteria called Clostridium perfringens. It's an anaerobic bacteria and it's commonly found in soil and dust. This bug proliferates rapidly, particularly in injured muscle. It releases toxins that induce blood clotting and muscle necrosis. This causes local ischemia and reduces the pH. And taken together, that makes a favourable environment for both this bacteria and other bacteria to then grow. Gas is produced in the tissues, and this can be felt as subcutaneous emphysema. The gas further helps with spread, especially in muscle fibres, as it opens them up and the infection can then spread quickly. It's important to note that lack of Krebs in the tissue doesn't exclude gas gangrene. The image on the bottom right shows another sign that can be seen, and that is brown-coloured bullae. This is a severely painful condition, and the pain is often described as being out of proportion with physical findings. That can be useful to help differentiate your diagnoses. You can see muscle swelling, and there's a rapid onset of muscle necrosis. And although creatinine kinase measurement is helpful, it's important to know that it's not sensitive or specific. So in general, gas gangrene starts with a cellulitic appearance. This can sometimes turn a yellowy bronze colour and sometimes forms bullae, although not always, and finally results in patches of black, green, grey or blue necrosis. Gas gangrene progresses rapidly, causing necrosis and sepsis, and this sepsis can progress rapidly to shock. Because it's so rapidly spreading, it's an emergency. In terms of investigations, as mentioned previously, blood should be done, clotting, CRP and cultures. Blood gases are also useful to check for metabolic acidosis. Imaging can sometimes be used, so for example X-ray, CT or MRI to see gas within the tissue or extent of damage to other tissues. Because this is an emergency, it needs aggressive treatment, and I'll go over some of those treatments in the next couple of slides. Second type of wet gangrene is necrotizing fasciitis. This is an infection of the soft tissue and the fascia, and it spreads through the fascial planes. Again, the toxins necrotize local tissue and clot blood. This leads to that stasis and a bacteria-friendly environment. Because a bacteria is able to move along fascial planes, it can spread very rapidly and deeply, and this may not be clinically apparent. This can result in a delayed diagnosis. And again, that sign and symptom of pain being out of proportion with physical findings. There are a number of types of wet gangrene. I'll just summarise a couple of them here. Type 1 is polymicrobial. Type 2, caused by hemolytic group A strep, and sometimes staph. This is a type of wet gangrene that's been described in the press as flesh-eating disease. Type 3, gram-negative and just one type of bacteria. Type 4 is caused by fungi. And a final type is Fournier's gangrene, which you can see on the top right image. And this is necrotizing fasciitis of the perineal and perianal regions and the genitals. So as I mentioned, in terms of signs and symptoms, a significant one is pain out of proportion with physical findings. And you can get some of the signs that I mentioned previously, so blisters and edema. Once it starts to spread, you can get systemic symptoms. And investigations are the same as I mentioned on the last slide. Specific to necrotizing fasciitis is a positive finger test, and this is pathognomonic. With this test, a 2 centimetre incision is made into the skin and the index finger is pushed in. It's positive if the finger passes through the subcutaneous tissue without resistance. So I'll talk about treatments on the next slide. It's just a note that, again, necrotizing fasciitis is an emergency and it has a 25% mortality rate. Treatment depends on the extent of tissue damage. I've listed the main treatments on the left here. So supportive treatment's important, especially if there are systemic effects. Broad spectrum or specific antibiotics if cultures have returned. Debridement, so cleaning away all the necrotic and dead tissue. Ultimately, amputation might be required, and this might need to be done as an emergency. So, for example, a guillotine amputation, where the amputation is done in seconds, or a formula amputation. One treatment that's in use, although not everywhere, is that of maggot therapy. And this is because maggots eat exclusively necrotic and dead tissue and leave healthy tissue intact. So we've just got a little image here to show maggot therapy. This is where maggots are being applied to a diabetic wound on the foot and a dressing applied over the top of them. So you can just see the maggots crawling behind that dressing. So they're cleaning out all the necrotic and dead tissue within that wound. So moving on from gangrene and on to secondary syphilis. And that's between 3 weeks and 3 months after the primary infection. The patient can develop secondary syphilis, and this is a very infectious stage. They tend to have systemic symptoms, so fever, headache, malaise, myalgia, arthralgia, lymphadenopathy, and other organs can also be involved. In terms of skin signs, they have a non-itchy, widespread rash. This tends to be over the trunk and can be on the palms and soles, and it consists of red or brown rough papules and plaques. There are a few different images here that show secondary syphilis, in particular on the palms and soles, and in the centre on the bottom is a condyloma lata. These are grey-white moist plaques that can occur on the groin, the inner thighs, armpits, under the breast, and in this image on the umbilicus. You can also get mucus patches on mucosal surfaces, and these are red raw patches. You can get hair loss. Another lesion that's specific to secondary syphilis is corymboid syphilis. And this is where you get central scaly plaques surrounded by erythematous papules. In terms of treatment, syphilis is very responsive to penicillin. It normally resolves after a few weeks, but it can reoccur or develop into tertiary syphilis. Herpes. Sorry, this is quite a busy slide. I've just tried to summarise it all on one page. So first of all, I'll talk about human herpes virus 1 and 2, also known as herpes simplex virus or HSV. This is spread by contact, so through an active mouth lesion or a lesion on the eye or genitals. When it's dormant, it lives in the basal root ganglia, and reactivation is within the dermatome of that nerve. Diagnosis is normally clinical, and how far it extends determines both diagnosis and treatment. So if it's a small area, it tends to be called a lesion or a cold sore. And these cold sores tend to have neurogenic prodromes that are described as tingling. These then form blisters, which crust over and ultimately heal. There are different treatments, and this depends on whether the lesion is oral or genital, whether it's a first episode or recurrent episode, and how many episodes the patient has annually. But for example, topical acyclovir can be applied at the prodromal stage. If HSV spreads over a large area, it can be described as widespread or disseminated. So for example, an atopic eczema. And in this case, it would be called eczema herpeticum. Eczema herpeticum shows multiple punched out lesions, papules, and vesicles, as you can see in the two lower images on the right-hand side. It responds well to acyclovir, but if it isn't treated, it can be fatal, especially in children. HHV3, also known as herpes zoster virus or varicella zoster virus or chickenpox, and then if it's reactivated, it can be called shingles. This is again a contagious disease. It consists of papules on an erythematous base. These turn into vesicles, they burst, form crusts, scab, and usually resolve without scarring. Shingles is a reactivation of chickenpox, and this chickenpox has been residing within the dorsal root ganglia. So again, this tends to show a dermatomal distribution that doesn't cross the midline. And I mentioned in part 1 that there's something called the Hutchinson sign. which is where shingles appears on the tip or the side of the nose, and this can indicate that there may be ophthalmic involvement. The next type of viral infection is called Exanthem. And this is an acute inflammatory widespread rash that accompanies systemic symptoms. So for example, fever, malaise, headache, or abdominal pain. These are quite commonly seen in children. In general, the systemic symptoms occur before the rash. And the rash or exanthem is formed either as an immune response to the bug, or reaction to the toxin, or a drug, or an antigen. Exanthems are normally symmetrical and they blanch. They're normally more extensive on the trunk than the extremities. And they often occur in groups. So, for example, all the children in a nursery might get a similar looking exanthem. Treatment depends on the cause, but in general, paracetamol reduces fever and moisturizers can help with itching. In general, it's difficult to establish a cause, although sometimes there are patterns of symptoms that do allow the cause to be identified, for example with measles. Viral exanthems tend to be associated with childhood infections, so for example chickenpox, rubella, slap cheek, measles. But there are also non-specific viral exanthems, and these tend to have a milder rash. Other things can cause exanthems, so bacteria, drugs, acute connective tissue diseases, and unknown causes, as for example with Kawasaki's disease or pityriasis rosea. With pityriasis rosea, there are a couple of images on the bottom right. The exanthem tends to be preceded by what's called a herald patch. You can see that on the left-hand image. And this is just an individual patch that's pink, scaly, and the scale tends to be around the edge of the lesion. It's about 2 to 5 centimetres in diameter, and it tends to appear between 1 and 20 days before the exanthem. Once the exanthem appears, it tends to be a whole body rash, again scaly patches or plaques, but these lesions tend to be smaller than the original herald patch. It tends to last 6 to 12 weeks, but it's typically self-resolving. Something that's important to determine when looking at an exanthem is whether it blanches or not. And the reason for that is meningococcal meningitis. So this is an infection caused by Neisseria meningitidis. Two severe consequences of this infection are meningococcal meningitis and meningococcemia or meningococcal septicemia. And so this is when the meningococcal infection spreads into the bloodstream. This is when we would see cutaneous manifestations, which would be a rash consisting of petechiae or purpura, and these petechiae and purpura don't blanch. There's been widespread public health messaging to explain the glass test, and there's a picture of that shown on the bottom. And this is where glass is pressed over the rash, and you can see through it so you can tell whether the rash blanches or not. Meningococcal meningitis is a medical emergency and delays can be fatal. But it's important to note that patients may also and only have a blanching maculopapular rash, especially in the early stages of the disease. And indeed, not all cases even have skin involvement. So the last slide on viral infections covers viral warts and Moluscum contagiosum. Viral warts are caused by HPV or human papillomavirus within keratinocytes. They result in papules or nodules with a hyperkeratotic or filiform surface. And you can see a couple of examples on the top of the slide, particularly the close-up on the right. They're most common at sites of trauma, so that's why they tend to appear on the fingers and toes. And they spontaneously resolve, albeit over a long period of time, typically up to about 2 years. Moluscum contagiosum. So the bottom images show this infection. It's caused by the pox virus, Moluscum contagiosum virus, or MCV. It's caused by direct or nosocomial spread. Normally there's a few weeks of incubation before the papules and nodules appear. They're skin coloured and have a dimple in the centre, and you can see that on both images, but particularly on the right-hand side. There can be just one lesion or they can appear in groups. And they tend to be asymptomatic, apart from when they become inflamed or infected, when they become itchy and sore. They usually resolve between 6 and 18 months, but they can last years. They tend to be more common in patients with atopic eczema, and lesions tend to resolve slower in these patients. So moving on from viral infections and on to fungal infections. So on this slide I'm going to talk about yeast infections, and in particular Candida infections. The most common species of Candida is C. albicans. This normally lives in the digestive tract, and it thrives in moist, warm areas. So for example, body folds, children's nappies, where it causes nappy rash, interdigital spaces. And it can also affect the mouth, where it forms white plaques, and the genitals, where you can see a white discharge. It's increased if patients are immunocompromised. The infection that results from Candida is called candidiasis. It's an erythematous lesion with a ragged peeling edge, and it may contain small pustules. Rather than being named by species, it's named by location. So for example, oral candidiasis or oral thrush, angular cheilitis, nappy rash, balantitis, vulvovaginal candidiasis, and the list goes on. Invasive candidiasis can lead to infection in the bloodstream, and that would be called candidemia. To investigate this infection, you'd carry out a skin scraping or a swab, and you'd send that for microscopy and culture. The scraping should be taken from the edge of the lesion, as this is where it's most likely to be positive. In terms of treatment, keeping skin clean and dry, and topical antifungals can be used like clotrimazole. If the mouth is infected, drops can be used like nystatin. Pessaries can be used in the vagina. If the infection is resistant, oral therapy can also be used. This slide covers another type of yeast infection, and that's Malassezia. This is a group of yeasts. There's about 14 species, and again these are found on normal skin. It's not understood why they grow more and cause more inflammation on some patients compared to others. There is increased incidence seen in humid conditions, oily skin, immunodeficiency, and when patients are sweating. Seborrheic dermatitis is caused by Malassezia, and this is also known as dandruff or cradle cap. You can see an image of cradle cap on the top right. Malassezia folliculitis is when the fungus is growing in hair follicles and causes inflammation. Tinea versicolor or Pityriasis versicolor. This again is a bit of a confusing name. Tinea is a ringworm. It isn't a yeast infection. We'll go through tinea on the next slide. Pityriasis describes a bran-like flake, and versicolor means multiple colours. Versicolor is caused by M. furfur, and it causes flaky discoloured patches on the back and trunk. It's usually asymptomatic, but it can itch. And there are a couple of images on the bottom that show Pityriasis versicolor. 3 images along the bottom. So brown is caused by enlarged melanosomes within the basal melanocytes. Pink is when there's also mild inflammation. And white is thought to be caused by a chemical produced by Malassezia that diffuses into the epidermis and impairs melanocyte function. Again, skin scrapings would be taken for microscopy and culture to keep skin clean and dry, and use topical or oral antifungals depending on the extent of infection. Moving on to tinea or ringworm. So this type of infection is also known as dermatophytosis. Tinea is an infection that's mildly itchy, asymmetrical, and annular in shape. It spreads with a slightly raised, scaly edge, and often with a clear centre. The diagnosis is based on location again, rather than species. So Tinea cruris or jock itch, which we can see on the bottom left. Tinea pedis, you can see on the top left. Tinea capitis on the right, and you can see, particularly with Tinea capitis and Tinea cruris, that annular shape. Onychomycosis indicates an infection in the nail. And finally, Tinea incognita is due to a change in clinical appearance that's been caused by inappropriate treatment. So an example of this would be if a topical steroid's been used. This wouldn't treat the tinea, It would reduce the inflammatory response, so the patient may feel that it's slightly resolving, but as soon as they stop the steroid, the infection then spreads. And this can continue in a cyclical fashion and explains a change in the appearance of the lesion. Again, investigation would be by skin scraping, and then treatment would be topical or oral antifungals. It's important to consider that recurrent fungal infections, and especially fungal mouth infections, can be a red flag for immunocompromised patients. Infestations, these are caused by insects. And on this slide, I'm just going to talk about two of those, although there are many. The first is scabies. This is caused by the Sarcoptes scabiei mite. The immune system reacts to the feces of this mite, and subsequent infestations get increasingly severe. It's very contagious and is often spread among children. It comprises papular lesions that are itchy, and this itch is especially prevalent at night. The top three images show scabies. And on the top right, you can see a linear skin burrow. This is pathognomonic for scabies, although it isn't always present. It particularly affects the interdigital web spaces of hands, and you can see that on the left-hand image. Again, for investigation, a skin scraping would be done, and treatment would be an insecticide such as permethrin. It's only effective if the whole body is treated, also if other affected family members are treated, and if all bedding and clothing is washed. The central right image shows Norwegian or crusted scabies. This results when there are many more mites, and it's caused by severe infestation. The result is psoriasis-like hyperkeratosis, and you can see that on the index finger, particularly of this patient. It tends to happen in immunosuppressed or debilitated patients that aren't able to scratch the mites out of their skin. It's a highly infectious state just because of the numbers of scabies mites present. The bottom two images show lice, and head lice are known as Pediculosis capitis. It's common in children, and again, it's spread by direct contact. It causes scalp excoriation, and on examination, you can see eggs or nits within the hair, and the image on the right shows those eggs. Treatment again is permethrin, treating all close contacts, and washing clothing and bedding thoroughly. There are lots of other bugs and bites and infections that we can talk about, but this is an entire subject in itself. So I'm just going to talk about two diseases that are more prevalent in the UK now. And they are Lyme disease and bedbugs. Lyme disease is caused by tick bite, and the Borrelia bacteria is what causes the infection. The infection is called Lyme disease or Lyme borreliosis. It can affect any part of the body, but it's commonly the skin and the central nervous system, the joints and the heart. There are a few stages to this disease. So first of all is localized Lyme disease. And you can see the image on the left, this is just showing that tick biting a patient's skin. And localized Lyme disease arises from here. You get erythema around the lesion, a flu-like illness, low-grade fever, fatigue, and joint pain. As time goes on, a target-shaped lesion develops, and this is known as erythema migrans. So it starts with a red macular papule. This red expanding patch of skin expands normally over about 7 to 14 days. It can reach dozens of centimetres in diameter and ultimately forms this bullseye appearance. It's not painful and it usually disappears within 3 to 4 weeks. Early disseminated Lyme's disease, and this normally appears days to weeks after the first bite. You get multiple erythema migrans, although they're normally smaller than that initial patch, and you can get early neurological signs and symptoms. If untreated, it can lead on to late Lyme's disease, which develops over months or years, and this is where you have chronic neurological disorders. Treatment in the early stages is with doxycycline. On to bedbugs, which you can see in the bottom 3 images. The left-hand side, this is a bedbug, normally up to about 5 millimeters long, and they're called Simus lectularis. They're a blood-sucking insect. They're attracted by warmth and they feed at night, And they can survive for up to a year without feeding, so they can be fairly difficult to eradicate. They hide in cracks and crevices of mattresses, bed frames, furniture and clothing. You can see a bite there in the centre. It's very small, and lesions can range from a small punctum up to a 5mm red itchy lump, which you can see on the right-hand side. Bites tend to be in a linear pattern on exposed areas, so the arms and legs, and they tend to resolve within a week if they're not scratched. Treatment's needed to eradicate bed bugs, and this tends to be in the form of insecticides and deep cleaning. That brings us to the end of infections, now on to emergencies. Most of the emergencies I've covered throughout parts 1 and 2, but I'll just go over them as titles now. So generalised pustular psoriasis, I haven't covered this, but that should be covered by the next dermatology lecture in a couple of days' time. Gas gangrene, necrotizing fasciitis, staphylococcal scalded skin syndrome, or SSSS. There are a number of blistering conditions that are emergencies, so immunobullous disease, pemphigus vulgaris or bullous pemphigoid, eczema herpeticum, and if there's ophthalmic involvement with herpes simplex infection. Meningococcyl septicemia, which is that non-blanching rash. And I mentioned in part 1 erythema multiforme, which isn't in itself an emergency, but it can progress on to Stevens-Johnson syndrome, SJS, or toxic epidermal necrosis, TEN, which are both emergencies. So SJS and TEN are different extents of the same condition. They're rare. They're an unpredictable reaction that isn't fully understood to drugs, infections, and other things like vaccinations or contrast media. The reaction affects the skin, mucous membranes, eyes, and genitals. It can have a prodrome, which lasts for several days and resembles an ERTI or a flu-like illness. It's abrupt in onset and comprises a tender erythematous rash that starts on the trunk, and this extends over the face and limbs in a matter of hours. There are a range of lesions: macules, purpura, diffuse erythema, targetoid lesions, flaccid blisters and erosions, and you can see some of these on the right-hand side. Ultimately, the blisters merge to form a sheath of detached skin, and you have skin shedding, which leaves an exposed red and oozing dermis. And you can see that particularly on the image on the left, that there are complete sheets of skin that are coming off. There are 2 or more mucosa involved, and the top right image you can just see that patient's lips, but the mucosa can be on the lips, esophagus, pharynx, upper respiratory tract, even eyes. And as you can imagine, the patient's in considerable pain and is very anxious and very ill. The differentiation between SJS and TEN is the amount of body surface area that's involved. So with SJS it's 10%, and with TEN it's more than 30%. And there's obviously an indistinct border between the two. It can be fatal. Serious consequences are in dehydration, infection, ARDS, GI ulceration, which can lead to perforation and intussusception, shock, renal failure, thromboembolism, and disseminated intravascular coagulopathy. In terms of treatment, removing the causative agent is the most obvious thing to do, so that would be stopping the drug or treating the infection. Ideally, patients would be admitted to ICU or a burns unit when they can have detailed supportive care. They should also receive focused care to the body part that's been affected, so for example the mouth. They shouldn't be given steroids without very specialist input, and they'll need psychiatric support and long-term care. Unfortunately, SJS and TEN does scar in the long term. Erythroderma. This is also known as skin failure, and it's widespread erythema due to inflammatory disease when 90% or more of the skin is involved. It can be caused by eczema, psoriasis, lymphoma, or drug eruptions. And you normally get scaling, which you can see in the left-hand image, about 2 to 6 days after onset. Consequences are dehydration, infections, and heat loss. And management is largely supportive, especially monitoring and controlling temperature, fluids and electrolytes. If a cause is identified, treatment can be given, so for example steroids in psoriasis. The final emergency condition I'm going to talk about is angioedema. This is similar to urticaria, however it's more severe as it affects the subcutaneous skin structures, whereas urticaria only impacts the epidermis and dermis. Angioedema tends to be less itchy than urticaria, and it shows a very marked swelling that's red or skin coloured. It's a result of edema due to increased vascular permeability, and there are many causes. It can be hereditary, idiopathic, drug-induced or antigen-driven. You can get urticaria alongside angioedema. Symptoms depend on location, so one of the main things we'd be concerned about is airway compromise. As with all emergencies, initial treatment is using A, B, C, D, E. With angioedema, you'd stop the precipitating factor. If there's airway compromise, they may need intubation. In general, urticaria is treated with antihistamines, angioedema with steroids, and anaphylaxis with 0.5 milligrams adrenaline, chlorphenamine 10 milligrams, and IV hydrocortisone. So that brings us to the end of dermatological pathologies that are most likely to be seen in the hospital. I hope that's been of some help. I'm not going to talk about the next few slides, I'm just going to show them quickly. And they are just quick summaries of the main conditions and one or two memory jogger words about each. These are just directly from my notes, so there's probably some spelling mistakes in there, but I just thought I'd include them so you can use them as a reference if you'd like to. And then finally, these are the references that I've used, mainly Dermat. They've got some great detail and images on there. The British Association of Dermatologists, they have an app which is quite useful. They've also got a handbook which is a really good summary of just some of the key points. And they also do a single sheet for each condition, which again is useful but patient focused, so is in slightly more lay terms. Finally, the Primary Care Dermatology Society, this is also useful. There's loads of great pictures on there. The only slight negative with that link is that some sections are still in process.